DTHF Research Meetings, your deep dive into the latest in research.
My name is Fiona. I'm the research assistant lead for Fast Prep. And I'm just going to talk about this abstract oral presentation that I presented at the International Workshop on Adolescents, SRHR and HIV 2024 in October. So this was done also in conjunction with the DANIELLE team at WITS. And I'd like to just also say thank you to the co-authors listed here. Okay, my slide is not moving. Oh, there we go. So just a little bit of background. The South African clinical guidelines for sexually transmitted infections, treatment and management recommend that all who test positive for STIs should be provided with a notification slip for their partners. But despite these guidelines, we know that the STI partner notification and treatment rates still remain low. And there's been quite a few barriers noted just around a lot of misinformation around how STIs are transmitted. So, for example, getting it from a toilet seat or what the symptoms are, etc., as well as interpersonal barriers that people experience, such as fear of stigma, being accused of infidelity by their partners, physical violence, as well as a reluctance to notify multiple partners or casual partners, or also partners that they obviously aren't in contact with anymore. So the aim of this study was to explore the barriers and the facilitators of STI partner notification and treatment using the nudge framework. This was in a group of adolescent girls and young women from Cape Town, South Africa. So we used a behavioral design approach to identify the challenges experienced by AGYW in notifying their male partners about positive STI diagnosis. We had 7 AGYW who had been in a recent STI study with an STI positive result, and 8 healthcare workers who attended the behavioral mapping and co-design workshop in Cape Town. And during the mapping exercise, we explored general insights, barriers, and solutions for the process. So just to start off, this is just an example of what the actual partner slip looks like at the moment. Well, you have actually changed it for now, but the original one. So you can see it's got a lot of wording. It's in 3 different languages, and it's got a lot of clinical information, but also, yeah, it just doesn't look great. It's on an A4 piece of paper, very small text, etc. So just in terms of the results and the insights from both groups, they were quite similar, but obviously just seen from different side of things. So with the young women, they said that they were often uncertain where they got the STI and when. They didn't have knowledge about STIs. They weren't sure if the treatments were effective. There was quite a lot of fear around, fertility. Can you have a child? Do they have, HIV as well? Will the medication work? Some said that they don't receive counseling around STIs or guidance on how to inform their partner. And some also just had a lack of motivation to speak to their partner, again, especially when they weren't in contact with them, or it was a casual partner. And a lot of the young women were concerned, they had concerns about partner reactions, and were especially worried about interpersonal violence. And especially, obviously, if they don't have symptoms, that would also be worrying for them. And then just, the design of the slip, they said it was complicated, it's too big. They didn't like it. And similarly, from the healthcare workers side, they also often felt that the young women are in denial after receiving the results. They often are not coming in specifically to be tested for an STI. So then hearing the results, it can be quite overwhelming and they don't absorb any information, especially when there's no symptoms. There's a lot of complex terminology. There's a limited understanding of STIs. There's fears around how it impacts fertility. And the healthcare workers felt that they wanted to be empowered to have the right conversation with participants based on each participant's history. So, you know, every participant or patient or client has challenges around their own experience with IPV, and whether, you know, if they have occasional or fixed partners, they wanted to be able to tailor the information accordingly. And again, similarly, like I said before, the reason might be for another visit, and so that makes it more difficult. And they need to find ways to discuss, ways to disclose other than the partner notification. And again, the slip, it looked like a legal document and was intimidating. So in a nutshell, we found that the barriers were the STI diagnosis, the STI treatment, and the PN counseling, and then the partner notification. So just a few quotes to support this. Around the STI diagnosis, a young woman said, "I don't think I have an STI. I have no symptoms. I don't believe I got this infection from my partner. I could have gotten it from a toilet seat." So with the STI treatment and partner notification counseling, a young woman said, "I'm scared my partner will blame this on me. The slip indicates the specific STI, and that's my personal information." And then the healthcare worker said, "It's too complicated, too much text, sounds legal, and I don't have the right tools to counsel the patient on partner notification." And then partner notification, around the young woman's, a young woman said, "I don't know how to start this conversation with my partner. I don't feel like I can convince my partner to go get treatment." And a healthcare worker said, "I wish someone else could notify the partner." So that's kind of talking about removing the young woman from the process altogether. And this leads us, to the suggestions. There was a suggestion to remove adolescent girls and young women from the process, to make it simpler, the slip simpler, and then also just to train healthcare workers to counsel and equip AGYW around notifying their partner. And this could be through education or through discussing like how they're going to communicate in the future. This could be through role play or just coming up with different scenarios together. So after that, we came up with a few low fidelity prototypes, and these were developed by the healthcare workers and the AGYW together. So they came up with a user-friendly PN slip or invitation card, and that can be seen at the bottom here. They thought of providing express treatment for the partner. So that's just treatment that would be taken home with the patient and given, they would then give it to their partner. And then a courier treatment for partners. So that would go directly to the partner, but that would need their consent. And then a video used for counseling. So this is just also, the pictures are just kind of like how I came up with some of these ideas. And then the different groups had to present. And so that leads us to the future work. So since the workshops, we have run similar workshops with the male partners to receive feedback regarding the prototypes and incorporate this. We incorporated this feedback, and kind of in a nutshell, a lot of that was around a lot of young men just don't want to be contacted by their partners. And then they all had differing ideas of like how they would like to be contacted, like through phone call, or some people thought that, an email, or so there were a few different suggestions there. And then Lauren in our team is also, she conducted more in-depth workshops with the youth reference group, and this was to inform a future study, which she's written up the protocol, and it's currently being reviewed by HREC, and it's going to hopefully be we plan to test the acceptability and the feasibility of these prototypes that have been created compared to the standard of care. And that is me. Thank you.
Okay, thank you, Fiona. I think you can just mute yourself. I feel like I'm hearing myself.
Sorry. Me.
Great. Great. Thank you for presenting on that. If does anyone have any questions, you can go ahead and unmute yourself, or any comments, any feedback. Now would be the time to ask Fiona. Lauren had a question. As the research, what would have been your ideal prototype? Fiona, if you want to address that. You can unmute yourself.
Sorry. Is it fine? Okay. Is this specifically, sorry, just to clarify, as the researcher, or what I think would be beneficial for the participants? Okay. I think in terms of, if I had to pick one, I think it would be focusing on the one that removes the young women as much as possible. So I think that if we could get around the consent, I think it would be the courier option, or also as a second option, I guess, the express treatment. But okay, so Lauren and I have obviously spoken about this quite a lot, but the problem is that a lot of, in the workshops again, there were a few participants who felt that it's not really, wouldn't trust like just receiving something by courier. It wouldn't be great in the community. People would ask questions. So it wouldn't necessarily be the best for that context. But again, all of these prototypes have pros and cons. So I think that's why we obviously have to test them. But yeah, I think that would be my preference. Thanks.
Okay, great. Then if there are no other questions, I think we can move to our next presenter. Lindsay, do you want to go next? Is that fine? Okay,
yeah, that's fine.
Great. Lindsay will unmute herself and then introduce herself, and then go ahead and present for us.
Great. Hi, everyone. Thanks for joining this afternoon. So my name is Lindsey de Vos. I'm a social behavioral scientist with the Desmond Tutu Health Foundation. And it's my pleasure to present our results on the Merck project, also known as PrEP Choice, where we developed a discrete choice experiment. And this was a collaboration between USC and the US, DTHF, FPD, and the Botswana Harvard partnership, and led by Dr. Devorah Joseph Davy. And so our main question was to look at preferences for long-acting PrEP and MPTs, or also known as multi-purpose prevention technologies, among pregnant and breastfeeding women. And we did this in 3 sites. It included Cape Town, East London, and South Africa, as well as Botswana. And our main findings shown that there was actually a dislike for vaginal rings, but actually that PrEP naive sites actually preferred clinic-based delivery, but also they were more concerned with effectiveness over the frequency of use if we look at long-acting PrEP modalities. And we felt that this was important because best practices should actually include certain populations sort of from the beginning to help product development and inform sort of preferences, to also inform the modality sustainability and efficiency as well. And we know with literature and with clinical trials that there's often underrepresentation of perinatal women, just also due to safety concerns. You would have known or read that there is a high disproportionate burden of HIV among young women in the Eastern and Southern African space, and that there's also unique barriers to this population when it comes to daily oral PrEP adherence. And the risk of HIV actually increases twofold during the perinatal period. So to give an overview of what the PrEP Choice study was all about, so we aimed to recruit a 1-to-1 ratio of pregnant and breastfeeding women to invite them to a discrete choice experiment with 450 women in total. And then just to mention that our DCEs were informed by in-depth interviews as well as focus group discussions. But then ultimately in our DCEs, we only included PrEP experienced women in Cape Town, and then East London and Gaborone were our PrEP naive sites. We also had a diagram during our qualitative interviews to help women think of hypothetical PrEP products or those that are currently in the pipeline, as developed by one of my UCT colleagues. And I won't be presenting on the qualitative findings today, but we did have a poster at the HIV R4P conference, and this was just a snapshot to show what women liked thinking about different long-acting PrEP attributes or characteristics to help sort of inform what attributes we should include in the discrete choice experiment study. So for those that might not be familiar with what a discrete choice experiment might look like, we ultimately identified 6 attributes that were important to participants, ranging from the frequency of clinic visits to discomfort, including side effects, the product type, combination prevention, also known as MPTs, where they could potentially pick up the PrEP product, but also the effectiveness in relation to how often it was used. And this ultimately created 40 choice sets. And we ultimately condensed the 40 choice sets into 10, it's actually 4 versions that each contained 10 questions each, and women were randomized to one of these 4 versions. And this is an example of what a DCE would look like. So as a participant, we would have a discussion about what are the 6 things that I'm presenting to you, what are the various levels to consider and what you find most important. And then ultimately, I would ask you if you prefer option A versus option B, and to consider which of these, if you see this as a whole package going down, which of these attributes do you find important? And then you can kind of assess throughout every time, if you do this across 10 questions, what really stands out to participants. As part of our DCEI analysis, so we stratified the data by study location, if you think back to the 3 different sites that we included, as well as the perinatal period, so pregnant versus breastfeeding, and older and younger participants. We used a mixed effects binary logistic regression model, which ultimately allowed us to have attribute levels sort of as comparison levels, which I'll explain in a moment as well. And also we had coefficients, which basically show the strength of the preference. And we also had our team at UKZN do a latent class model analysis, which helps look at preference heterogeneity. So we often know we might not be able to offer all of these modalities or packages, but we can see potentially where most of the people sit in terms of their preferences, or how we could potentially group some of these things. If we look at the participant demographics, the overall age across the different sites was 26 years of age. Participants in Botswana were more likely to report being unmarried, not living with a partner, and approximately 20% across the sites didn't know the partner's HIV status. So we didn't see a difference in terms of preferences looking at age and the perinatal period. So I've included the main effects that we saw across the sites overall. So this is everyone combined. And then I'll also discuss the differences that we saw by site. And on the left, you'll see the different attributes again, which I presented earlier with the different figures with their reference levels in brackets. And on the right, you'll see the coefficients that shows the strength preference. And if it's negative, often participants disfavored that attribute in relation to its reference level. And the confidence intervals show the variability in preferences across the participants. But what we really saw as one of the main negative preferences was for vaginally inserted PrEP as compared to oral PrEP, as well as implants. We saw a strong preference for combination prevention compared to HIV only, and also participants disfavored going elsewhere to pick up PrEP as compared to the government clinic. And with effectiveness in relation to how often the product was used, there wasn't so much a difference between if it was used daily or monthly, as long as it was effective. But if it was less effective, people generally then didn't want to have to take it as often. If we look at the differences by site, we see a similar trend leaning towards the vaginally inserted PrEP modality, and this was especially strong in Cape Town. We also saw in East London and Cape Town that there was an indifference for injections versus oral PrEP, but there was actually a preference for injectable PrEP in Botswana. And then again, a preference for MPT, so combination prevention, which was especially strong in Botswana. And then we again saw a similar trend where each site preferred government clinic pickup, but there was actually an indifference between community delivery and government clinic pickup in Cape Town. And then in terms of the effectiveness and how often PrEP was taken, the PrEP naive sites, which were East London and Gaborone, were actually more concerned with the effectiveness of the PrEP product, whereas in Cape Town, they were actually more concerned with the frequency of use. With regards to the latent class analysis model, so if we had to group people's preferences, we see that the largest group sits in what we call the comprehensive delivery seekers, and they had a less pronounced aversion to vaginally inserted or implanted PrEP. The smallest group we titled the physical and physiological prioritizers, looking more at sort of structural barriers and side effects. But they also had disfavored implanted PrEP and seemed indifferent to injections or vaginally inserted PrEP. And then our other group were the vaginal insertion avoiders, who also preferred combination prevention, but also preferred other delivery options as compared to government clinics. And so these findings give us insight into the preferences amongst this population when we look at modality, pickup locations, and effectiveness. We saw a strong inclination for injectable PrEP, and I think this is due to women's familiarity with contraceptives that are commonly used in South Africa as well. And it's not to say that we should not pursue vaginal rings or disfavor vaginal rings. I think especially in the PrEP naive sites, it could definitely benefit from demonstration programs because in the in-depth interviews, we also saw a lot of hesitation around discomfort or how it was used. And also, I think with the PrEP naive sites, potentially they preferred government clinic due to familiarity or potentially integrated services. And the findings can help sort of inform HIV prevention strategies and implementation strategies, but also to align as we think about product development and the needs of women, that these align with their preferences and needs as well. And ultimately, I'd like to acknowledge everyone that contributed to this project. And thanks so much for your attention.
Okay, great. Thank you, Lindsay, so much. Are there any questions for Lindsay? You can go ahead and unmute yourself and ask a question or put a question in the chat that I'll we can monitor as well. No, I think, Lindsay, everything was very clear.
Thanks.
Okay, then I think we will move on to our next speaker. And let's see, Danielle, are you ready to present? I know you were ready with your camera earlier and we tested everything.
Okay, let me
Oh,
share.
we have lost your sound. I think, oh, no, wait, there we go.
Can you hear me?
Yes, sorry, I was on
Okay.
mute, so that was my bad. Okay, so Danielle, yeah, we can see your screen, so you can go ahead, introduce yourself, and then go ahead with your presentation.
Okay, just let me know if I start cutting out or if you can't hear me well.
Okay, will do.
Okay, so hi everyone. I am Danielle Giovenco. Oh, I've lost my teams. Okay, you can see me, right?
Yes, we can.
Okay. Yeah, so I'm Danielle Giovenco. I've been honorary faculty at DTHF for several years now, but I'm based at Emory University in the United States. So thanks again, Nadine, for moving this an hour, so it's not quite so early over here. So this is a talk I gave at HIV R4P just this past October in Lima about mental health and substance use among South African adolescent girls and young women enrolled in the FAST PrEP program. Okay, so as we know, the PrEP implementation among South African adolescent girls and young women is essential to ending the HIV epidemic. But there has been some evidence that mental health and substance use disorders may impact PrEP engagement. So in this study, we explored how these factors relate to persistence of adolescent girls and young women in the FAST PrEP district-wide PrEP program. So I'm going to move through this explanation I gave about FAST PrEP very quickly, since I'm sure most, if not all of you, already know this. But so the FAST PrEP demonstration implementation project is an ongoing decentralized PrEP program in the Klipfontein Mitchells Plain Health Subdistrict near Cape Town that is designed to introduce, scale up, and evaluate new biomedical HIV prevention products through differentiated models of service delivery using a hub and spokes framework. So in the hub and spokes model, mobile clinics and government facilities, which are the central hub, provide PrEP initiation, and then refills can be accessed by way of various spokes, such as schools, courier service, or youth clubs. And the FAST PrEP study aims to distinguish PrEP persistence patterns across different PrEP modalities and from multiple PrEP delivery platforms to inform PrEP implementation and the provision of PrEP choice among adolescents and young people. So the goal of the project is to have greater PrEP coverage among sexually active adolescent girls and young women, their sexual partners, and other key populations, and ultimately to have reduced HIV incidence. So the FAST PrEP program aims to enroll 25,000 adolescents and young people. Rollout started in July of 2022, with PrEP being offered to young people at 4 community-based mobile clinics and 12 health facilities, and enrollment is ongoing through 2025. And the program offers integrated, comprehensive sexual reproductive health services, including contraception and STI management, in addition to PrEP choice. And then it also uses a peer-led model for service navigation. So in this analysis that I did, we were interested in understanding if mental health and substance use were associated with retention in PrEP services among adolescent girls and young women. So females aged 15 to 29 years who received a 1-month PrEP supply at enrollment into the FAST PrEP program prior to April 3rd of 2024 were included. And this is just when I pulled the data and ran the analysis. So our exposures of interest were depression and anxiety symptoms measured by the PHQ-4 and alcohol misuse measured by the AUDIT-C. So both of these were measured at enrollment into the FAST PrEP program. So a total PHQ-4 score greater than or equal to 6 was used to indicate moderate to severe depression and or anxiety symptoms. and a total audit C score greater than or equal to 3 was used to indicate a positive screen for alcohol misuse or hazardous drinking. So all adolescent girls and young women who received PrEP at enrollment received a 1-month supply, and then they were asked to return after 1 month for their first follow-up visit. So our outcomes of interest were retention in the FAST PrEP program and persistence on PrEP at that first follow-up visit. So basically, did adolescent girls and young women attend that first follow-up visit, and was PrEP dispensed at that first follow-up visit? And then for our analysis, we just used log binomial regression to estimate associations between moderate to severe depression and or anxiety symptoms and alcohol misuse at enrollment and retention in the program and persistence on PrEP at that first follow-up visit. Okay, so our sample was 7,317 adolescent girls and young women who were all included in this analysis. This table shows a few of the demographic characteristics for this analytic sample. So most notably, I guess, is 78% were enrolled at a community-based mobile clinic. So the first table on this slide is the distribution of the PHQ-4 in the audit C. So 8% of adolescent girls and young women were categorized as having moderate to severe symptoms of depression or anxiety in the past 2 weeks, and 49% reported alcohol misuse in the past year at enrollment. And the second table shows the distribution of our outcomes. So 31% of adolescent girls and young women attended their first follow-up visit and were considered to be retained in the FAST PrEP program. And 24% had PrEP dispensed at their first follow-up visit and were considered to be persistent on PrEP. So my understanding is the audit C and the PHQ-4 were not asked of everyone in the beginning of FAST PrEP. So I think I was told they were asked of every 6th person. So that's why our sample here is about 4,000 instead of 7,000. But we expect that this missing data would be missing completely at random. So there was no significant difference in depression or anxiety symptoms by the age group shown here, but we did see greater alcohol misuse and better retention and PrEP persistence among older age groups. Okay, and this is our main regression result. So these models were adjusted for age and mobile versus clinic enrollment venue. And you can see that moderate to severe depression and or anxiety in the past 2 weeks at enrollment was associated with greater retention in the FAST PrEP program. And alcohol misuse was associated with both greater retention as well as PrEP persistence at the first follow-up visit. So this is the opposite of what we were expecting to find. So to unpack this a little bit more, we decided to stratify these findings by age group. So these are age stratified results. So we looked at 15 to 19-year-olds, 20 to 24-year-olds, and 25 to 29-year-olds. And we found that these associations that we observed in the full sample were only present among adolescent girls and young women who were 15 to 19 years of age in the age stratified analysis. So specifically, adolescent girls and young women who reported moderate to severe depression and or anxiety at enrollment were about 1.5 times as likely to be retained in the program and to be persistent on PrEP. And then adolescent girls and young women who reported hazardous drinking in the past year at enrollment were about 1.6 times as likely to be retained in the program and persistent on PrEP. For the other two age categories, you can see that all the 95% confidence limits here for the estimated prevalence ratios overlap the null value of 1. So overall, our results reveal an unexpected relationship between mental health, alcohol use, and PrEP persistence among younger adolescent girls and young women. So we've theorized a few potential explanations for these findings. So FAST PrEP utilized the peer navigator-led model at the facilities, and mobile clinics were the adolescent girls and young women were enrolled, and we know that peer support can improve adherence outcomes. So we think it might be possible that adolescent girls and young women who were experiencing mental health challenges may have experienced greater support benefits from the peer navigation, and then they may have been more motivated to come back to the program to receive additional support. We do know that adolescent girls and young women, that many of them elected to return to the location where they are enrolled as opposed to picking up PrEP from another location or having PrEP delivered, which may indicate they were seeking interaction with the peer navigators or the program staff. It's also potentially possible that adolescent girls and young women who experience mental health challenges may feel more motivated to persist with PrEP because they were maybe more aware of the risk due to of HIV due to their mental health or substance use, or maybe unmeasured covariates. Ultimately, those facing mental health and substance use challenges may have, we think, just found support within the FAST PrEP program, which enhance their likelihood of continued engagement. There are several limitations for this analysis. So particularly because there's a lot of unmeasured confounding in our analysis, because this was an implementation program and not a research study. So that kind of limits our ability to interpret these findings causally. And then we also dichotomized our exposures for ease of interpretation, which may obscure some nuanced effects, such as those of mild depression symptoms. Yeah, so I think our next step for this analysis is to write this up into a brief report. So if anyone has any kind of thoughts about explaining these findings, that would be useful. But that's all I have, so thank you.
Great, thank you. Thank you, Danielle, for presenting those findings. Do you think with adding more participants, this might shift to more of a pattern that you were expecting?
Yeah, that's something that I was just talking about when I was there a couple weeks ago. I think because the sample is so large, like in our analytic sample, we had about 4,000. That's, you know, so much power for the analysis that we're doing, especially because there wasn't a lot of covariates to adjust for, that I don't think adding any more sample will make much of a difference. I think we have, yeah, so I think our plan is to kind of write this up as is, as opposed to adding more in. And interestingly, when I did present this at R4P, I had people come up to me after saying they've seen this in other samples, where they've kind of seen the opposite effect of mental health on adherence. So I think I should also do some research into kind of like what other explanations have been proposed.
Okay. Okay, are there any other questions for Danielle before we move on to our next presenter? Deborah, you have a question? You can unmute yourself and ask.
Hi, Danielle. We also found, I think I told you this, that we found an inverse association with alcohol use and better PrEP continuation in pregnancy, which we found was very counterintuitive. So you might want to look at sexual behaviors and the relationship with sexual behaviors of these people might be also having higher risky sexual behaviors that might be driving their PrEP use.
Yeah, that's interesting. I didn't know that you also found that. So yeah, and we were also thinking this could just be related to things that we just don't have. So sexual behavior could be related to potentially like IPV. So yeah, we definitely don't have like kind of the data in this program to explore that. So yeah, we'll definitely kind of maybe cite your paper in the kind of discussion as other potential explanations. Have you published those findings?
Great work. I'll send it to you now. Yeah, we have.
Great, thank you.
Okay, great. Then I think we will move on to our next presenter. Pippa, if you want to go ahead, can share your slides, unmute yourself, introduce yourself.
Sure, Nadine.
If you are ready.
Yep, all ready. Let me try and just share my slides.
Yes, we can see them. Just put them into full screen.
Fabulous. Just trying to get rid of that. There we go. How does that look?
That looks perfect. You can go ahead.
Fabulous. Okay. I'm very sorry that I'm not able to share my camera today, but I've just had a few issues with my laptop.
Don't worry.
To say
All good.
thanks, Nadine, for putting this together, and to everyone for listening. It's so lovely to hear all these presentations. Some I'm hearing for the second time. And yeah, thinking of R4P. So my name's Pippa. I'm one of the medical doctors with the Desmond Tutu Health Foundation. And my main role is as the safety medical officer for the FAST PrEP study and for Prepare to Choose. This is also a presentation that was done at HIV R4P, and I'm certainly honoured to present it on behalf of the FAST PrEP and Prepare to Choose study teams. I'll be talking about the use of HIV rapid detection tests when initiating long-acting CAB for HIV prevention within an implementation science project. So R4P asked us to do these summary slides. The main question was what's the risk of the third and fourth gens in comparison to NAT testing? What we found was that acute HIV infection was not detected in 3 out of 862 people, and that there was actually no difference observed between the third and fourth gen tests. And why is it important? And that's because viral resistance mutations might develop if CAB-LA is started during acute HIV infection. And these results will help inform HIV testing policies when that testing is not feasible, and public health benefit must be weighed up against individual risk. So really just to talk a bit of background about the study and the study setting, I think most people on the call know all about FAST PrEP, which is an implementation science project evaluating the uptake, coverage, and effectiveness of a youth-focused decentralized PrEP program. It's based also in the Klipfontein-Mitchells Plain area, and multiple PrEP modalities are offered across multiple delivery platforms as part of a differentiated service delivery model. And these platforms include mobile clinics, local clinics, schools, a courier service, youth clubs, and a quick PrEP depots. We call this our hub and spokes model. FAST PrEP provides integrated sexual and reproductive health services to young people aged 15 to 29. And you can see all the different things that we do within our mobile clinics, including HIV counselling and testing, risk reduction counselling, HIV PrEP choice counselling. We provide condoms, lubricant, PrEP, generally oral PrEP, and the DAPI ring. We do STI testing for chlamydia, gonorrhea, and syphilis. Pregnancy screening, we provide contraception, GBV and IPV assessment and response, mental health screening, counselling and referral, and TB screening. And then nested within FAST PrEP is our smaller phase 3B study called Prepare to Choose, which is obviously my focus today. And Prepare to Choose, it is investigating the delivery of CAB as an HIV prevention option within the PrEP choice context in our real world setting in Cape Town. And we aim to enroll up to 1,800 people, including adolescent girls and young women, pregnant and lactating people, intimate male partners, gender and sexually diverse people. We have 2 sites, a mobile clinic and a government primary healthcare facility. And in comparison to FAST PrEP, our participants are offered a choice of oral PrEP, either daily or event-driven, or the DAPI ring, if appropriate, and CAB-LA. We follow them up for 18 months. Our participants can switch at all time points, and our primary outcome is looking at persistence at 7 and 18 months. And so far, we have enrolled about 862 people who've started CAB. We're still waiting to enroll another 38 pregnant and breastfeeding women on CAB as well. So the HIV testing strategy, what did we do within Prepare to Choose? As I mentioned before, initiation of CAB during acute HIV infection can result in a delayed immune response to HIV, which makes HIV RNA undetectable, and this reduces the generation of anti-HIV antibodies. And this is known as the Levi syndrome, long-acting early viral inhibition. So if the Levi syndrome exists, there is a delayed diagnosis of HIV and an increased risk of HIV drug resistance. We don't know the impact of this, but this is something that is very, very worrying for us, particularly, you know, when our participants are not coming back if they've started CAB. Getting back to this little study, the NATE HIV testing, it does detect HIV earlier, we know that, but it's more expensive, it's more resource intensive, and there are limitations at very low viral load levels. So, to provide evidence to confirm or refute the superiority of these NAT tests and inform the use of rapid tests, we compared this NAT testing, the counsellor-administered 3rd and 4th gen tests that are done at weeks 0, 4 weeks into CAB, and 28 weeks thereafter, and we compare that to the NAT testing. And I'm going to be presenting the baseline CAB initiation data. What we did was we looked at the HIV rapid tests for everyone initiating CAB between February and June. The 3rd and the 4th gen rapid tests form part of our 3-step process to screen for HIV, which I'm sure everyone knows so well. The 3-step process is number 1, checking for HIV exposure in the past 72 hours, where you would rather give PEP instead of PrEP. We also look for signs and symptoms of acute HIV infection. And then our 3rd step, testing for HIV, is doing our rapid test combined with the NAT testing. We did change our HIV testing strategy as time went on within Prepare to Choose. Initially, the mobile clinics, if you remember, I said we had 2 sites, a mobile clinic and the government clinic. The mobile clinic initially used 4th gen rapid tests, which is the HIV antigen antibody tests, combined with the NAT testing. And the government clinic, which is Voyani, were using a 3rd gen test combined with the NAT testing. However, after we did miss a few participants who actually had HIV with these rapid tests, we then changed it, and now all participants who started CAB and who are being followed up on CAB are having both a 3rd and 4th gen rapid test done in combination with NAT testing. And just to say that the viral load result, the NAT result, was not known before we gave the CAB. So the rapid test result we obviously had immediately, but we had to wait to get that viral load result back. In Prepare to Choose, we do other baseline tests, liver functions, Hep B, we do our STI testing, pregnancy, TB screen, Audit C, and PHQ-4, which Danielle has also spoken about. These are our results. So out of the 862 people who started CAB, majority were adolescent girls and young women. Most were single, and I think the majority had had an HIV test within the past 3 months. What our test results show is looking at them. Just under 200 had only a 4th gen test, about 275 had a 3rd gen test, and the majority had both. And what's really interesting to see is that of the 666 3rd generation tests that were done, 664 were truly negative. With the 4th gen, it was very similar results, which shows a very high specificity. So these rapid tests have been working very, very well. A different way to look at it is to look at the number of people where we missed HIV with these rapid tests, and that was a total of 3 out of 862 people. So the rapid tests are actually working really well compared to the NAT testing. Obviously, those participants who we did miss, those first 3, and they remain the only 3, even 6 months down the line, with further testing, they were obviously recalled for additional testing, HIV confirmatory testing, resistance testing, And all 3 were started on first-line ART TLD within 5 days. I definitely won't go through all of this, but yeah, it just shows the viral loads. The viral loads range between 10 million and 9,251 at baseline. All of those missed on rapid tests. And yeah, all 3 were obviously adolescent girls and young women, and all had used PrEP in the past, which is also interesting. So in conclusion, we all know that CAB increases options and choice for HIV prevention. We absolutely have to try and do this safely, and we have to ensure that the HIV status is negative before we start CAB. NAT assays are safer and do detect HIV earlier, but the rapid test also performed really well. And the fact that there was no difference between the 3rd and 4th gen tests is also very interesting. We thought that the 4th gen tests, which detect antigen and antibody, would have detected HIV earlier, but we didn't really see that. So what is the most suitable, safe, and feasible way? Are we okay with just one rapid test, a 3rd or a 4th gen test? Should we do a combo of 2 rapid tests? Should we do a rapid test and maybe an ELISA? And what about NAT testing? And obviously point of care is preferred. Acute HIV was not detected in a very small percentage of people. The negative predictive value of rapid tests was excellent, and public health benefit must be weighed against individual risk for same-day CAB initiation. And of course, I want to thank our incredible teams and everybody sitting in this room who has listened to me with my croaky voice. Sorry, I'm off homesick. Thanks so much.
Thank you, Pippa, so much, and thanks for presenting. And your voice was not croaky, so we understood everything very nicely. Are there any questions for Pippa before we move on to our last speaker? Lots of applause. Questions in the chat? I don't think so. Okay, then I think we'll move on. So then we'll move on from Jen Tess to Jenny, who will be our last presenter. So Jenny, I know you said your camera wasn't working today. That's fine. You can just share your screen. There we go. We can see it. And I'll hand over to you to briefly introduce yourself and then present the data you have for us today.
Awesome. Thank you so much, Nadine. And yes, apologies for no camera, but hi, everyone. My name is Jenny, and I am currently a PhD student with Linda Gale Becker. And today I'll just be sharing what I shared at the International Workshop on Adolescents, SRHR and HIV. It's a very long title now, back in October. And essentially I shared our data from Fast PrEP. So it was evaluating PrEP initiation among AGYW who are pregnant and mothers in Cape Town, South Africa. So why do we care about this population? AGYW, so as a background, AGYW in Eastern and Southern Africa are still incredibly vulnerable to HIV acquisition. They accounted for 6 in 7 new HIV infections among adolescents aged 15 to 19 in sub-Saharan Africa. And in South Africa, there's still, in 2023, there were 7.7 million people living with HIV. And pregnancy and breastfeeding also more than doubles HIV acquisition risk. But despite that, PrEP uptake among AGYW, especially those who are pregnant or mothers, is under-researched. And just as context, South Africa introduced oral PrEP back in 2016 and also updated their guidelines to include pregnant women in 2020. So that's the background. And essentially, the aim of my analysis was to evaluate PrEP initiation among AGYW who are pregnant or mothers. Danielle and Pippa have already gone over this, so I won't go over the study design for Fast PrEP, because I also know that we're running out of time. So for the participants, I grouped them into 2. So there's the AGYW who are mothers and or are currently pregnant, and then those who are not mothers and not pregnant. For the quantitative analysis, I essentially looked at PrEP initiation and only those who initiated PrEP, and looked at the factors that were associated with PrEP initiation. So that was delivery location, how they became aware of PrEP, Fast PrEP, if they had an STI in the past month, their perception of their HIV acquisition risk, their relationship status, and if they had a HIV test in the past 6 months. And using logistic regressions, I then compared AGYW who are pregnant and or mothers versus those who are not mothers and not pregnant, and I adjusted for age and relationship status. So looking at the results, which was collected between August 2022 and June 2024, 4,609 AGYW initiated PrEP, and of those, 25% of them were pregnant and or mothers. And then breaking that down even more, there were 22% who had a child but were not pregnant at the time, 1% who already had a child and was also currently pregnant, and 2% were pregnant with their first child. So looking at the PrEP initiation location, the majority of these AGYW initiated in a mobile clinic. So as you can see, the 2 team trucks, and then 44% enrolled in a government clinic, and then 3% enrolled in other settings. And when looking at the logistic regressions, those who were non-mothers and non-pregnant had a higher odds of essentially enrolling in a mobile clinic. But then when we just look at mothers and those who are pregnant, they had higher odds of having higher perception of HIV acquisition risk, having had a HIV test in the past 6 months, learning about fast PrEP through fast PrEP champions, and this was also adjusted for service location, and also having had an STI or their partners having had an STI in the past 6 months. So what does this tell us? The AGYW who are pregnant or mothers have heightened vulnerabilities to HIV acquisition as well as STIs. And there's a significant role of peer-led initiatives, as we could see, because obviously a majority of the pregnant and mothers learned about fast PrEP through the fast PrEP champions, who are essentially peer navigators. And there's obviously a need for targeted interventions that also include comprehensive SRHR education and services. So not just obviously about HIV, not just about PrEP, but also STIs. And we need to develop strategies that address the unique circumstances of AGYW who are pregnant and mothers. And just to say as well, this was a preliminary analysis for my PhD, but the full analysis will look at the initiation as well as continuation and how the delivery methods might affect continuation. And I will also be looking at comparing those who are AGYW versus those who are older, and comparing those who are pregnant versus those who are not pregnant. But yes, that was a really quick blitz through my abstract, as I am aware that we're out of time. But thank you to everyone, obviously, for listening, and the fast PrEP team, the participants and the funders, etc., etc. Thank you so much.
That's great. Thank you so much, Jenny. Thanks for catching up with time. I don't think you left out anything critical. Everything made complete sense. We're looking forward to the full analysis and your full PhD as well. Are there any questions for Jenny? Anyone, or any comments, any feedback?
DTHF research meetings, your deep dive into the latest in research.